Thank you very much. It's an enormous pleasure to be here. So, really, I want to ask a ridiculous question. And that question is, if you've got diabetes, then who should make the treatment decisions? Is it the chap on the left who attends Kidney Week, Diabetes UK, does his RCP, does all the rest? Or the machine on the right, which has got absolutely no clue about medicine? It can only letters it can manage are A, C, G, and T, and it's pretty useless. But I hope by the end of the talk, you'll think that just sometimes we should ask the grey box of a machine. I want to start with a patient. This is Lily, and at 3 months old, she was desperately ill. She had been started to vomit over the previous week, and nobody was sure what was wrong with her, but when she finally came in, it was found that her pH was 6.8, her glucose 54, and she was in diabetic ketoacidosis. That hadn't been expected because you don't expect a 3-month-year-old to get ketoacidosis. It was clearly recognized that she was making no insulin, a C-peptide was undetectable, she was treated with basal bolus insulin as type 1 diabetes. And she had all the problems of a young child with type 1 diabetes. Her problems were hypoglycemia at night. It was the variability, and her parents would set an alarm at 3 a.m. every day to check her blood glucose. She didn't have any detectable C-peptide, which is consistent with her needing insulin, but she didn't have any islet autoantibodies, but there are people with type 1 diabetes that don't. But Lily did not have type 1 diabetes. And you can say that with absolute certainty because she was diagnosed at 3 months. And any diabetes diagnosed before 6 months is monogenic and not type 1 diabetes. And so what that meant was that the etiology here was not an autoimmune disease that was HLA associated. Indeed, when we look at people with permanent diabetes, what you can start to see in this picture here, if we had a, nope, so was that the HLA in the first people diagnosed in the first 6 months of life is the same as the normal population. And so there's only this HLA predisposition if the diabetes occurs after that. So we knew that she had neonatal diabetes, but to be honest, at this time point, it didn't make much difference. The treatment was still insulin. But things were to change in 2004 because Anna Gloyn, working with Sean Ellard in the Exeter laboratory, was to define that the commonest cause of diabetes was a mutation in the KR6.2 subunit of the ATP-sensitive potassium channel. And what Anna showed is the vast majority of these were de novo mutations. If we could have a pointer, it would be a great help. If there was one here, but it's gone missing. Ah, thank you. Brilliant. It's not who you know, it's what you know. Okay, so what we can see in the middle picture is that we were dealing with mutations that were actually stopping ATP binding to the potassium channel. And because of that, it wasn't closing. Normally, in the presence of ATP, we can see this work from Fran Ashcroft in Oxford, and what was she able to show is in the wild type, in the presence of ATP, the channel closed. But when we had a mutation that was stopping the binding of ATP, and that meant the channel didn't close. And so what we had was within the beta cell, there was all the ability on the left-hand side in order to be able to sense the glucose. On the right-hand side was all the mechanisms to allow us to develop, to produce insulin. But what was lacking was the communication between those two. Now, we're extremely fortunate to find this because there had been 20 years of science going on this potassium channel before we were to find it. And what that showed was that this potassium channel could be closed by a non-ATP sensitive route by sulfonylureas. Routine treatment in type 2 diabetes, never used in people that were insulin dependent because they had no role. But suddenly there was a hypothesis which you could make at this case, which was that could sulfonylureas actually bind to the KATP channel and depolarize the membrane and allow insulin secretion. So the difficulty we had here was it wasn't like the wonderful example you've heard about in HUS, where there wasn't any treatment. We had a perfectly good, safe treatment, which was insulin. And were we going to have the courage to stop a perfectly good, safe treatment that was used throughout the world and try something else? And sometimes you need a bit of luck to encourage you to be brave. And this was the luck that we had, because amongst the patients that we diagnosed was one 46-year-old gentleman from Brazil. And he'd been diagnosed at the age of 3 months. And when he was diagnosed, his patients were devastated. Not only did their children have a chronic illness, but also he had a chronic illness that they could not afford the treatment for. So they asked the pediatricians, do you have anything cheaper? This was a caring pediatrician, and he said, well, there was something which had recently come on the market called sulfonylureas, and they could try tolbutamide. They tried it, and indeed, 46 years later, he was still on sulfonylureas. He had the best blood sugar of anybody in our cohort, and he was the only person that we could measure C-peptide in. Interestingly, he'd gone on and become a very successful lawyer, and one thing lawyers have throughout the world is enough money. So when his 2 children developed diabetes in the first 3 months of life, he could pay for insulin. So now his 2 children were both treated with insulin. So instantly we had the question of who was on the right treatment, and more importantly, could those that are on insulin swap over to tablets? And at the end of the day, you just had to ask the families if they were prepared to try it. We didn't have a rationale. There wasn't a set dose to give to patients in this situation. And so what happened was there were about 5 physicians throughout the world who started simultaneously to treat patients with the family's consent with sulfonylureas. And by far the best documented one was this one in Norway from Paul Nolstad. And what they did, and what you can see here in yellow is the insulin dose. So the first month they just recorded the blood sugars, which are shown in blue, and the HbA1c, which are in green. And then very gradually in red, you can see the sulfonylurea dose was increased by a tiny amount every 3 days. But after a month, what had happened was the insulin dose had halved. But if anything, the glucose was better. And indeed, after 2 months, and carrying on to a dose in a 5-year-old of 5 milligrams, which is the equivalent of a normal adult dose, they had completely stopped insulin. So what we now is a patient that was insulin dependent, who given a sulfonylurea had become insulin independent. Now, you'll all be aware that this is the worst quality of research that you can do. Case report, really you shouldn't base any clinical management on it. So what you have to do is a trial. But we had a problem because we needed to do a trial against insulin treatment. And what happened was all the families had got to hear about this. They'd helped in our research. And so they said, well, we've tried the injections before very much. We only are going to go into the trial if you'll let us take the tablets. So we had to do the next best thing, which was 50 consecutive patients. And we found that 90% of these were able to stop their insulin. But what we hadn't expected was this result. Because what we found was that in every single case, the HbA1c improved, and improved without there being an increase in hypoglycemia. And if any of you have struggled with people with type 1 diabetes, you will know this is our dream, is to get better control without hypoglycemia. And yet the sulfonylureas had achieved that. And the key thing was that what was lost, the injections didn't matter to these people. They could cope with the injections, but what they lost was the fluctuations. The glucoses were lower, but the main thing was they weren't fluctuating, and that meant the parents didn't need to get up at 3 o'clock at night. And it transformed the life for the children, because suddenly they were happy to play in the football team. They went on the school trip to France. They were doing sleepovers, things they hadn't done before because of their insulin dependence. And so really it made a massive difference. People were concerned, well, this was sulfonylureas, and weren't they going to exhaust the beta cell? Well, that's not true. We've now done the 10-year follow-up, and what we see is the HbA1c has been maintained, if anything, on a slightly lower dose of sulfonylurea than they were on before. And amazingly, After 700 years of follow-up, there have been no hypoglycemic episodes with loss of consciousness or seizure in the whole cohort. So this is a treatment that not only is good initially, but also we now know lasts. Now, any of you who work in a research group will know your university says if you discover anything, make sure you patent it. So we were duly good little scientists and we patented it. But then we realized there was only going to be a few patients that we could give this to. We'd have to sell the patent on to a company and then we'd have major problems. So we undid the patent and decided to do the opposite, which was to offer it free to anybody diagnosed under 6 months anywhere in the world. And we were helped by the Wellcome Trust with that. So that immediately removed a barrier that was stopping genetic testing. The result of that was that now over 2,200 people diagnosed under 6 months from 103 different countries have been tested in Exeter. And of course, there'll be many other people tested in other labs rather than our own. And half of these have come off and gone on to sulfonylureas. But what that's meant is that we have the best research resource for finding new genes. If you haven't got one of these potassium channels, you had it in a different gene. And what that has meant is that over the years, we've now discovered 26 different genetic types, of which 19 were defined either by our group or in collaboration with our group. And we've been able to show that there are multiple different causes of this, and each one gives scientific insight into either the development or the function or the destruction of beta cells. And one of the fascinating things we found is that we're able, with all these different subtypes now, they come to us just with diabetes, and we're able to say things about their diabetes, such as whether they're likely to go into remission if it's transient, whether they'll need exocrine replacement, whether there's an alternative like sulfonylureas that could be used. But also we've got details about neurological features and other features, so implications for the extrapancreatic phenotype. And this has really led to a revolution in how things are done. In the old days, what we would do is we would take patients and we would diagnose them, we'd do the testing according to what syndrome they had. And if you look at something like Walcott-Rallison syndrome, which some of you will know is neonatal diabetes, but then you can have bone problems and also liver failure, sometimes associated with kidney failure. And if we were diagnosing them more than 4 years after they were diagnosed, then they were most likely on the far side to have diabetes and bone or liver, or diabetes and bone or liver problems. But if we diagnose them early, within 12 weeks of being diagnosed with diabetes, the vast majority had diabetes only. And as this has got around as being standard treatment, and with us offering it free, this means we're now getting samples on an average of 5 weeks from the diagnosis of diabetes. So no longer do people with Walcott-Rallison present with bone and liver conditions, they now present with diabetes only. And this has led to a real change in how we do medicine. Because this is the traditional genetic way, which is you have a poorly defined phenotype, like say diabetes at 3 months, and then as you get other features like the kidney and the liver, then that leads to a clinical diagnosis. And then once you've got a clinical diagnosis, you're doing management based on that. You then will say, this must be Walcott-Rallison syndrome, and the genetic test just confirms it. The new world, which is going to come into all branches of medicine when things are highly genetic, is this approach, which is that you have a poorly defined phenotype. You do rapidly multiple tests. We're using a gene panel for all the causes of genetic diabetes. And then the genetic test makes the diagnosis rather than the clinician. And then now you're dealing with someone with Walcott-Rallison who you can try and prevent the liver problems or prevent the liver failure. And really, this is really what genetics offered us. We no longer need experts. You don't need someone to recognize the phenotype. And the great thing is, if you're told what the diagnosis is, it's very easy for you to read about it because you know exactly what condition you're dealing with. And so this is really the new approach and the new paradigm for where we're going. Now that's relatively simple if what you're dealing with is genetic disorders. But where we started in Exeter was dealing with MODY. It's a familial form, a dominantly inherited form of genetic diabetes that comes on early. It's not insulin dependent, often shown by them stopping their insulin and being fine, and it's a defect in the beta cell. And this was clinically defined when I first started doing my research. As all you needed to do was go out to a family wedding or family event and collect DNA from all of them, and then you had enough power to find a gene, this meant it was very easy to find genes in monogenic diabetes like MODY. And that's what we did in the late 1990s. And we turned MODY from a clinical type into genetic subtypes. And the reason this matters, and the reason this is now offered throughout the world, is because it mattered in terms of clinical features and treatment response. And really that's when genetics is going to make an impact, when it can tell you how to treat them. So glucokinase patients have such a stable mild hypoglycemia, they need no treatment. They will get no complications, and they don't respond anyway. But the other forms of MODY, HNF1 alpha and 4 alpha, have progressive hypoglycemia, and they're very sulfonylurea sensitive. Many of you will have patients in your clinics with HNF1 beta, and those really need insulin therapy. So if you like, this is really simple. This is precision medicine at its best. Subtypes, clear diagnosis, an easy way to make the diagnosis. But it doesn't always work. This is Dan. He was diagnosed at 16 at a glucose of 19, HbA1c of 9.5%, and was instantly diagnosed as having type 1 diabetes. He went on a basal bolus regime and had real difficulty with hypos. He took along this family tree showing that he had multiple family members who were slim with diabetes, all diagnosed between 15 and 40. What he was told was, we'll never take you off insulin, so what's the point? We're not going to do genetic testing. So you can have all that knowledge, and if it doesn't occur for the clinician at the time that they're seeing the patient, if they've got a strong idea of what type 1 diabetes is like, then there's a problem. In this case, it was HNF1 alpha MODY. They're extremely sensitive to very low-dose sulfonylureas, and on 20 milligrams, he had an excellent HbA1c, and having had real problems in his A-levels, he managed to become a vet at Bristol and stop having hypoglycemia. So the problem with MODY is the problem of knowing who has diabetes, who should we test. It's not a problem of what tests should you do if somebody comes in and says, I've got MODY, because very few people will. And that's the problem, that most people with diabetes are not recognized as having MODY. So why aren't we better than that? I know what you're thinking. You know what diabetologists are like. They're all pretty useless. But it is difficult. And it's not just the ones in the southwest are having a problem. So this shows the distribution of MODY across the country. And what I would point out is that even the darkest blue, which is the southwest, which is where all good things happen, is still only 30 to 50. But what we know from community surveys, there's 150 per million is the true incidence. So in other words, we're all missing cases. And what we found is those people who we finally genetically define, most are initially diagnosed as type 1 or type 2. And on average, it takes 7 years for a clinician to finally realize that he's not dealing with type 1 or type 2. So we've got a problem. So why is it so difficult? And this is the problem, is there's no absolute cutoff. It's not like the 6 months where you can all go away and say type 1 diabetes doesn't occur before 6 months, and you'll be right. The problem we've got here is these variable phenotypes, age of diagnosis. It helps distinguish, but it doesn't do it absolutely. BMI doesn't distinguish from type 1, but does distinguish from type 2. HbA1c is helpful, but not enough. But even parents with diabetes, which you normally get in MODY, you can also get in type 1 and type 2. So you've got this real problem, which we face in many conditions. We can try and reduce it down to simple binary criteria, but we're going to miss a lot of cases. So what do you do when you've got this? Luckily for me, Bev Shields, who's a statistician in our group, said, Andrew, this is easy. All you have to do is make a probabilistic model using all of this data. Don't turn into subgroups, just make a model. And what she created was first a web-based app, and now an app that you can download, Diabetes Diagnostics. It's free to download, and these are being used worldwide in order to diagnose MODY. So you may think, well, what's that? That's never going to be better than a clinician. Well, I foolishly said that, and I foolishly agreed to go head-to-head. I lost. So if you ever want to know if someone's got MODY, don't ring me up and ask me or send me a long email. Just go on the app and use probability, and it works. So what we've done is we've gone from clinical type to subtype to improve clinical care. If you ask me where I think the future is, it's that MODY testing will need to get very close to diagnosis. So I think in children, the problem is we're trying to find 3%. So if you always say, I've never seen a MODY patient, you're 97% correct if you're talking about a child. So it is difficult, but I think if you take everybody who's antibody negative and test those patients, that's going to be the way. And so it no longer becomes waiting for a doctor to recognize it, but rather making it routine care. What about the more common types? You say, well, that MODY stuff, we haven't got that in our family. Type 1 or type 2, probably the best example of precision medicine, different etiologies, different treatments. The reason you need treatment with insulin in type 1 is because you have no endogenous insulin. And normally we can separate type 1 from type 2 because type 1 are young and non-obese, and type 2 are old and obese. The problem comes when you start to get dichotomies. And things can easily go wrong when there are conflicting priorities. And I show this picture not because we're in Brighton and it's a political time, but because Theresa May was misdiagnosed with type 2 diabetes when she developed diabetes age 52. She was treated with diet and exercise, metformin, no effect, metformin and sulfonylureas, before finally it was realized that she had type 1 diabetes and she was put on insulin. That took 9 months, and I guess she had some pretty good doctors looking after her. And the good thing for her was that the wrong diagnosis was then corrected and the correct treatment given. But most people in our clinics, they're then thought to be an insulin-treated type 2 and get the wrong treatment. It's also difficult when you're young and obese. This is somebody from our take. His name is Mr. 33. He was 33 years old. He was a factory worker. He drank Coca-Cola when he was thirsty, came in slightly dehydrated with a BMI of 33, and his glucose was, of course, 33. And normally when I ask what the treatment is, we get split about 50-50 as to what we would do. And normally the hospital doctors would put him on insulin, and the GPs would keep them off insulin. And so the real question is, can genetics help these kind of problems? And now this is not going to give an absolute answer. Again, it's going to give a probabilistic answer. And this is Richard Oram, who many of you will know, who did something very simple but very clever, which is just to turn the complexities of HLA and genetic predisposition into a simple risk score, into a simple number. And then what you can see is that there's a clear difference between type 1 and type 2 on that score. If you have a high score, you're more likely to be type 1. If you're a low score, you're unlikely to be type 1 diabetes. But the answer is not to use this on its own. Stop looking for a magic biomarker, a magic genetics. You have to put things together. And this is what happened in a study done with Angus Jones. And what we found was that age of diagnosis, or BMI, or the type 1 genetic risk score, or autoantibodies, all behave about the same. But if you put them all together, you can get a 98% accuracy. So it's really by combining things, and I think that is the future of where we're going to go. So just finally, what about type 2 diabetes? Can we subdivide that? Can we start to talk about groups? Now, some of you will have seen on the BBC that there was a lot of publicity for a paper in The Lancet saying there were 5 subgroups of diabetes, not 2, and that was suggesting there were 4 subtypes of type 2. There are problems with this. It's very hard to apply. It was cluster analysis. The groups weren't etiological or exclusive. But the main question was, do they improve prediction or outcome of treatment response? And really, there are two ways that you can do this. You can either take the clinical features and put people into subtypes and then define different clinical course and treatment, or you can take the clinical features and create a model for all the different outcomes. And just to summarize our work, what we found was you are much better off trying to have a model for each clinical outcome, have a model for renal failure in diabetes, and that can be separate from a model for heart failure. And it can be separate from a model of response to therapy. They don't all need to go together in a full subtype. And this is just the data of a recent paper where we compared using groups where there was very little difference when the treatment went with or without or was discordant from the recommendation of the group, but it was much better when you did it on a model. And I think the future for type 2 diabetes is not making subtypes. I think it's actually making models for the different outcomes and putting them into GP and hospital schemes, systems, so you get an answer. So in summary, molecular genetics is now used in routine care in diabetes. Under 6 months, you'll get an answer in 85% of cases, and the genetic diagnosis will determine the treatment and the follow-up. MODI is really important, but it's difficult, and there are new tools there. The type 1 genetic risk score can help you diagnose type 1 diabetes. In type 2 diabetes, use clinical features to model outcomes, not genetics. And finally, the integration of molecular genetics into clinical care is a real challenge. But I'll just leave you that please sometimes ask the grey box when you want to make a decision about treatment. Thank you very much.